Okay, well, welcome everybody. Thank you for joining us today. My name is Marcia Rankin-Smith. I'm a strategy and transformation lead at DXW. And for this session, I will be acting as facilitator. May I politely request, although I think you've already done it, that you keep your mics on mute for the duration of the presentation. And we'll keep your questions to the end and answer them in a open discussion at the end. You are welcome to drop comments and questions into the chat if you'd like throughout the presentation, but we'll pick them up at the end. Our session runs from 12 till 1 today, and the session is being recorded and can be shared later through the digital festival. So to begin with, I'd like to introduce our panel for today. So first of all, we have Dylan Roberts, who is the Chief Digital Officer at York and Scarborough Teaching Hospitals NHS Foundation Trust. And we have Leanne Coker, who is our Senior Service Designer at DXW. And we have Kira Little, who's our Design Researcher at CCD Design and Ergonomics. And a quick introduction to our companies. So DXW design and deliver services in collaboration with public and third sector organisations. We also support organisations to shape their vision and they form their strategies and delivery plans. And we've been doing that for about 13 years. And we've worked in a wide variety of environments, third sector and public sector, and focusing on a lot of different service areas and topics. Our offices are based in London and in Leeds, but we work nationally. And CCD is a design consultancy that's driven by human behaviour. They help their clients to think and develop and focus on people. They use processes like design thinking for creative problem solving that are centred on the needs of people. Their team brings together a unique blend of disciplines from interior design, graphic design and industrial design, and work alongside ergonomists and psychologists. The project that we're going to be talking about today was a review of urgent referrals at the Trust. The Trust commissioned the project. Just letting somebody else in. The Trust commissioned the project in February 2021 using the Yorkshire and Humber Discovery and Development Services Framework. DXW and CCD delivered the project in partnership over 10 weeks using service design techniques to understand what was working well, what was challenging, and where improvements could be made. In the session today, we're going to share our experiences of that project, talking a bit about the challenge for urgent referrals, how we approached the service design challenge, what we learned along the way and what we recommended to the Trust at the end of the project. And then we're going to talk a little bit about some of the challenges that make change difficult in an NHS Trust. And after that, we welcome your questions and we welcome an open conversation with you to talk about similar experiences or anything else that we can share together. And this is an outline agenda of what we're going to cover today. It's a little bit fluid, and we just hope that we can have quite an open conversation at the end. We've probably got about 20 minutes or so of slides to share with you first. So before we begin with the slide deck, I'd just like to ask Dylan if we could provide some context on why the Trust wanted to initiate this project and what challenges they faced.
Thank you. Thank you, Marcia. Hello, everybody. Yeah, well, just a bit of context to start with. Clearly, York and Scarborough Trust, bit of background. Clearly, it's a 24/7 every day of the year. Trust treats about 130,000 patients per annum. And I think, as is the case with the rest of the healthcare system, but in particular right now, under extreme pressure in terms of trying to deal with the demand on services, and not least the demand on services in terms of coming into ED and emergency care. So by way of example, the pressures aren't just because of COVID-19. There are now, because of that, quite a bit of a backlog in terms of elective care, 104-week and 52-week type waits, and real pressures across the systems in terms of being able to discharge folk out of the hospital in social care and other places. So it's important that we need to be as effective and as efficient as we can be. And when it comes to urgent referrals, what we're talking about there is the scenario when and the urgent referrals can come from different places, but primarily they come from primary care. But urgent referrals is the scenario when Mrs. Jones turns up to her GP, is looking fairly anemic, could potentially be the case, and the GP requires some additional expert input, potentially from a consultant, might think she needs a blood transfusion or something like that. That type of thing is an urgent referral. How it happens now is not as efficient as it could be. It generally results in the GP attempting to make a phone call to the consultant, to the right consultant, hoping that the consultant might answer the phone. In many cases, if the consultant does answer the phone and is able to provide some advice, maybe there is no need to come to the hospital. But in many cases, it might result in the consultant needing to book further appointments, maybe diagnostics, if the blood transfusion, for instance, maybe that type of a thing. So lots of onward work that needs to be done. And in many cases, it's complex because every patient and situation is different. So there could be a different mix of pathways, which is appropriate at different times. It means in many cases, sorry to say it, that, and this is the same in many trusts, the consultant might be writing something on a note, having to run around the trust to try and get something sorted. Whilst all that's going on, the patient themselves are potentially waiting, unsure what's happening. Feedback is poor, and ultimately it can be extremely inefficient and a cause of great angst, not just for the patient, but also for the people running around in the trust to deal with this situation. Now, how do we look to sort this? One of the things I've been very keen, I'm quite new as the Chief Digital and Information Officer for York and Scarborough. I've just been there just under a year, and from my perspective, one of the things that I wanted to bring into play in terms of considering digital solutions is more of a service design and user-led design approach, and it's something I'm trying to introduce into the hospital. I think it's difficult to bring it into the NHS, which might be some of the conversation that we have today. So what I was really keen to do in the first instance is just recognise the fact that, there's no magic technology solution for this. It's really important that we understand what the problem is, and it's also really important that we involve people in the design of any future model or any future solutions if we're going to get any success from it. So from my perspective, success comes from working with people, not doing to people, and that's something which I think has proved successful in lots of things that have been done in the past. So in that regard, we went, as Marcia described, out to the framework which is in place across Yorkshire and Humber, which was led by Leeds City Council on behalf of the Yorkshire Humber Care Record programme. So we let the tender through that, and we secured DXW and CCD as a partnership to come and sort this out. And part of today's session, I'm just going to pass over to Leanne any second now, is to talk about how we did that piece of work. I think, as well as trying to resolve the actual issue at hand, this project was also a bit of a showcase project for the trust to be able to demonstrate how a more user-led design approach can deliver success and is better than more of the top-down approach we often get in the NHS from a technology point of view when people are generally done to. But there are challenges with doing that, and we'll be talking about them throughout the session today. So can I pass over to you, Leanne?
Yeah, thanks so much, Dylan. Hi, everyone. My name's Leanne Coker. I'm a service design lead at DXW, and I was the service designer who worked on this project. So I'm going to talk a little bit now about the service design approach that we took. As Dylan mentioned, this actually represented something that was quite new and different for the trusts, and it was actually really, really effective at a way of making headway in this really complex problem space. And then afterwards, we'll pass over to Kira, who's going to talk about the outcomes and some of the really kind of exciting and interesting solutions that we came up with, but just making some time now to talk about how we got there, because I think there's some really interesting lessons, I think, to be learned. So yeah, our service design approach, what were some of the key elements of it? On the next slide, please, Marcia. And where did we start? So some of the key activities that we adopted. So the service design approach, it isn't a kind of very linear or prescriptive thing, but there are a number of kind of philosophies, approaches, sometimes very practical frameworks that we use, and we kind of, every project is about choosing a bespoke mix of those, and this is what worked here. So I'm going to talk through what those elements were. We actually started with some horizon scanning activities, and what that basically, if you visualize looking to the horizon, looking, learning about the landscape. So in this case, this looked like speaking with colleagues from other parts of the NHS, NHS Digital. We spoke with people from NHS Scotland, really trying to just understand a bit more about urgent referrals in a broader context. And just helps us build some background and awareness of the problem space that we're working in. It was a really, really important foundational activity. We then moved on to an inception workshop, which brought together the core team of people involved in the project from the Trust, as well as our delivery team of CCD and DXW. And this is something that is very standard part of our practice, and we get together in a workshop. In this case, this was all being done very much kind of at the start of lockdown. And we were trying to answer a number of questions together in a workshop setting. We did it using Miro, and what you can see at the bottom here is a screenshot from the Miro board that we used. If we were together in real life, we would have been sticking post-its on the wall. Actually, Miro worked fine. We were able to do it online. And the key questions we were asking at this stage were, why are we doing this work? Yes, we had a brief and we'd worked to it, but we're really trying to unpack that and make sure we've built a shared understanding of what it really means and how we're going to prioritize. So why are we doing this work? Who are the users? What outcomes will they get? What are the organizations and stakeholders that are involved? Really importantly, what outcomes are we looking for from this discovery? What do we need to learn or prove along the way? What other work relates to this? And starting to think about some of the difficulties and risks that we might face. So a really exploratory session, just trying to get us on the same page and kick off the project. And answering these questions led us to be really, really clear on some goals for the discovery, how we want to frame the problem. And that in turn helped us devise a plan. How are we going to approach this project over the next, 7 weeks? So on the next slide, please. So the discovery goals that we came up with out of those inception activities, 2 of them. First off, it was about understanding the current situation. So we wanted to map the Trust's current urgent referral service, including the problems and pain points and the things that are going well. So really important foundational stage to the service design approach, understanding how things are working right now, what's good and what's bad about it. And quite often, and as was the case here, we're talking about complex processes, systems of systems, many actors, and there wasn't just a process diagram that we could pick up and work from. It was very much about trying to map out how things are working right now, which is really common actually across all the projects that we work on, really, that you don't have that documented view of what's happening now, and just doing that is really valuable in itself, building up a shared understanding of how things are working right now. And then the second goal was more future looking, so envisioning a future service, including recommendations, concept designs and prototypes for the highest value improvement ideas. So this is really setting out a vision for urgent referrals in the future. How could it be better? Very concept stage at this point, because we're talking about a discovery project. So on the next slide then. So unpicking that a bit as well, when we're thinking about, okay, what does that future view need to look like? helps to frame the problem a bit more specifically. This is a really important step in a service design approach, problem framing. And what we mean here is going beyond just saying, let's improve this thing. What do we really mean by that? Like, what are we actually trying to do? And quite a nice way of framing problem statements can be, how might we? So it keeps it quite open. You're not trying to be solution specific at this stage, but you're trying to think about areas that you want to explore. And actually, this is really tough. This can be a really difficult process. Took us quite a while to align on these. It was through a series of workshops and conversations with the delivery team and members of staff from the trust. But this is what we arrived at. 4 how might we statements. How might we enable better clinical conversations between GPs, hospitals and departments? How might we improve the urgent referrals patient experience across the trust? How might we operate a more efficient urgent referral service that makes the best use of its staff and clinical facilities, being aware that, you know, chucking loads of extra resources at this thing was not an option. And how might we better support and empower staff across the trust to provide an excellent urgent referral service? And these problem statements actually really seem very simple when you've got there, but actually getting there, arriving at these simple statements was tough. It's a valuable activity to do. So you've got clear lines of investigation around conversation, around communication, around efficiency, what's the patient experience and what's the staff experience. And these problem statements then feed really, really nicely into, okay, what is this research going to look like? What are the questions that we're going to be asking? So on the next slide. So that research we were able to then launch into, and the bulk of it for this project was talking to staff across the trust. So here we're talking about the urgent referrals kind of system of systems. There are many individuals and teams involved across different kind of organisations within the trust. So between hospitals, between primary care and in a hospital setting. And the key user groups that we identified were GPs, people working in same-day emergency care or acute care, as it may be called. And there was a bit of a difference between, important to note, we were talking about 2 hospitals here. There's York Hospital and Scarborough Hospital, both part of this trust. So there were some differences and we needed to speak to staff from both. Staff in the emergency department, people involved in diagnostics, bed management, patient flow, and specialist consultants, and there were a number of areas. So there's a huge number of staff, and we were just trying to get a broad and representative sample. We ended up completing 20 interviews, and we had a good spread. This table kind of shows we were trying to get a good spread between the hospitals and all those different user groups. Also within that, we're trying to get a mix of different grades of doctors, or staff, you know, from very experienced to less experienced, because they all had different perspectives. So that was a big chunk of it. And in those interviews, what were we trying to learn? On the next slide, please. So first off, it was about examining the process as it is. And we found this 3Ds framework really useful for structuring those interviews. This was a really interesting part of the project, actually, because it represented a real fusion of kind of a service design type approach, news centre design, and something more ergonomics, HFE, a really structured way of decomposing complex processes. It worked really well here, and I think it really helped us as a research team and design team not get completely overwhelmed by this kind of spaghetti of interconnected processes. And it was about really being very structured when we were talking to people, understanding their process in this three kind of stage way. Declare, so the 3D stand for declare, which is the information that's required by each team or role we were speaking to, what's coming in. Discuss, which loosely means the process and decisions, the kind of thing that's happening, they're doing with it, and then decide the outcome. This idea of info in, decision making, and info out, we use to structure our conversations with each of those actors in the system, and we were able to use that structured insight to build up a big picture of how the whole system works. And we also asked, importantly, questions about what does urgent referrals mean to them. I think it was really clear at the start that it's not a well-defined thing, and that became quite important to us to try and get a bit better understanding of what does it mean to different people. And then importantly, their view of future and ideas for improvement, and also the impact of COVID. COVID was very much live and a thing at this time, and it was affecting practices now, and is it likely to have a long-term effect? So that made its way into our line of questioning too. So on the next slide, in addition to the interviews, which were done remotely, again because of COVID mainly, but we were able to do a site visit and visit both hospitals midway through the project, and after we'd done a lot of these interviews. Actually, it helped to do that after some of those first interviews, because we had some context and we had some things that we wanted to follow up on and explore, see for real. And it also provided an opportunity for some of the team to actually kind of walk in the patient's shoes, walk the patient journey from the front door, and understand kind of what their experience of it might be whilst all this stuff is happening in the background. The next slide, please. So patient feedback, obviously that featured as one of our problem statements. How might we improve the patient experience? And of course, fundamental to that is getting feedback from patients themselves. Vitally key. They are the end user in this case, and getting their input is really, really central to any kind of service design approach. It proved really challenging to actually get patient feedback or do research with patients within the short timeframes of this project. After exploring a number of options for doing this, we found a really successful strategy, and really recommend actually anybody else working in a healthcare setting could explore this, which was to link up with a junior doctor to collaborate on a patient feedback survey, or collaborate with a doctor in a way of getting feedback from patients. It was a win-win, because actually doctors, as part of their training, need to do some work on service improvement. They have a service improvement objective. So doing things like patient surveys helps them with that. And it gives us a way to get input from patients safely and ethically, without needing to go through the very lengthy approvals process that's required if it's branded as clinical research. So that worked well for us here. We used the site visit as an opportunity to launch a patient feedback survey. So again, working closely with this junior doctor, created a simple feedback form, both paper version, and we left a stack of copies with pens and a post box to post it in the outpatient department. And staff were there, encouraging patients to fill it in. We also created a Polish version of the form, because we had learned from staff interviews there were a significant number of Polish patients using the services, and that we had a kind of hint that language barriers were a problem. So we made sure to do that. There was also a digital version of the survey that could be accessed via this QR code that was on a poster on the wall. So this was successful in the end. Unfortunately, the timeframes, this was like a 7-week project. The timeframes of getting all of this done and getting the data back and analysing it was just outside of what could be done as part of the discovery. So essentially, we ended up getting the responses back after the project had come to a close. However, that data is left with the junior doctors, so they've got it to continue their service improvement work, and it's there as a valuable resource. The trust have it, it's being securely stored and can be used as a valuable source of insight for future projects. So on the next slide, please. So all of that stuff was a kind of discover phase of our work, and it was about research and learning. We then moved into the ideate and design phase, and we modelled that actually on a design sprint style approach. Some of you may be familiar, this book, the Google Ventures Design Sprint, how to solve big problems and test new ideas in just 5 days. It is a really, really bold claim. And we didn't we didn't necessarily do it all in 5 days, but what we did do was, and what we often do actually, is take inspiration from this approach. And again, it's about customizing and making it work for a particular context. So yeah, at its heart, it's a 5-step process: map, sketch, decide, prototype, and test. And it is just a focused and intense way of understanding a problem and getting to the point of having ideas to test. So it wasn't appropriate here to kind of do it in 5 days. That approach really does involve like completely gathering a team and completely immersing yourselves in it for 5 days solid. It wasn't a reality, it wasn't feasible. You know, we're talking about involving very, very busy clinical staff. It wasn't feasible to do that. So instead, on the next slide, we formulated a 3-workshop approach that still followed that same kind of philosophy. And you can see the 3 workshops in the blue, red, and purple here. So in the first workshop, we came together and it was about mapping the challenge. It was about reviewing the opportunities that had arisen from all of this research that had happened and mapping them to those problem statements. So referring back to what we were trying to explore in the first place, and doing some prioritization. I think key point here was that it was big. It was a huge problem area. There were lots of kind of opportunity areas that we could explore. We did some prioritizing at the end of that to really focus in, okay, let's try and take one chunk of this problem and do something with it. So then after that, and I think Kira's going to talk to you about what that prioritized bit of the problem was. The second workshop then moved into inspiration and ideation. So doing a bit more horizon scanning, looking outside again, but in a much more focused way. What are some of the kind of solutions that we can find from elsewhere in healthcare, but also outside of healthcare that sort of address this kind of problem? And then starting to do the fun bit with sketching, literally sketching, drawing elements, coming up with ideas that how we might address these problems. Between workshops 2 and 3, the design team were then able to go away and create some prototypes and storyboard for some of those ideas. And then workshop 3 was an opportunity to come back, present those, test them and iterate them. And this was a workshop done with representative GPs and members of staff from across the trust. And yeah, so the outcomes of this process, that we had 2 concepts that came through. We got to them in a really, really kind of focused and quick way, and we came out of it with some low fidelity prototypes. I'm going to hand over to Kira now, who's going to actually kind of shed some light on what that prioritized opportunity area was and what some of those solutions looked like.
Thanks, Leanne. Hi everyone, my name is Kira Little and I'm a design researcher from CCD. So I will take you through this section about what we learned, and it responds to our discovery goals of mapping the current and envisioning a future service, which Leanne has already spoken through. So I'll cover in this section what it is that we did, well, how we defined urgent referrals, the patient journeys, as well as information flows and technology, the area we prioritise to redesign and why and who it applies to, and then finally the 2 big ideas which Leanne has mentioned. So on the next slide, please. As we've already referenced, one of the initial challenges we faced was the question of how big does this go and what do we mean by urgent referrals? So we really had to get to grips with what is urgent referrals, and after a number of interviews and sessions with the core trust team, we came to this working definition, which is shown before you. Essentially, referrals are from primary care GPs and associate clinicians, self-presenting patients, and inpatients who can go home that day if referral is completed from the unit or ward doctors. The referrals are usually for specialist opinions and investigations such as X-ray, MRI, and other medical diagnostics. So on the next slide, please. What exactly then does make a referral urgent? Shown here is a high-level map of some of the referral pathways we looked at, but what we found most interesting is that through our research we have identified that different people actually have different perspectives, so what is urgent to one may not be to the other. So some of those opinions and insights that we gathered included definition by exclusion, so everything that's not emergency, so must be seen within 24 hours, or routine. Also, an individual's patient journey can be upgraded or downgraded to urgent along the way. Physically presenting at hospital currently appears to increase how quickly a patient is seen by a specialist, which isn't necessarily true. And finally, urgency is just about transferring risk. On the next slide, please. So here in front of you is just a high-level map of the existing service. So again, this was one of our main goals for this discovery phase. And this service is provided via a complex system that presents in a number of different variations of journeys as well as touch points. A system can be viewed from many different perspectives, so multiple maps are required. If you think about using Google Maps or similar, you can change the layers of the map that you might be interested in looking at. So you might do aerial view, street view, satellite, etc. So we chose to explore the information flows, patient journeys, the front and back of house experience for both staff and patients to get those different layers of perspective. It's big, it's complicated, and it's by no means linear. So we quickly appreciated that the right balance of breadth and depth was necessary for this short project. We had to zoom in and focus on a particular pathway to move forward into the next discovery goal to envision a future service. Next slide, please. So having mapped the patient journeys, information flow, use of technologies, etc., we zoomed into this priority pathway to reimagine. You can see along the bottom of this screen here, we've just got some of the post-its, which actually came from another working session together to identify those different steps. This pathway was based on a combination of the insights from the specialisms we'd come across in the interview phase, as well as our on-the-ground experiences at both York and Scarborough hospitals. It references the pain points that were repeated and highlighted a number of different people, as well as those what is urgent referral responses, the transfer of risk, and the misbelief that physically presenting at hospital will increase how quickly a patient is seen by a specialist. Next slide, please. So the research identified a subset of patients who could avoid lengthy waits in ED if they were supported to wait safely at home for next day urgent care. So ED is the emergency department, also known as A&E. So the pathway would be appropriate for elderly and frail patients for whom unnecessary time spent in hospital can have negative health impacts that outweigh the risk of waiting a day or two for referral. Those with complex or reoccurring needs and comorbidities, patients with good cognitive function who are able to engage with remote support provided, and or those with additional support available at home from family members or carers. The expected benefits of this pathway for patients is reducing unnecessary admissions and the positive health outcomes associated with that, taking pressure off of the emergency departments, freeing up cubicles, as well as freeing up ward beds as well, and generally just a better patient experience. Next slide, please. So how do we do it? These are the two big ideas that came out of the design sprint ideation. The two ideas are different, but not mutually exclusive. They could be complementary if implemented together to support next day urgent care. So these ideas were born out of the ideation session, but it really came about by focusing on our prioritized area that we've just quickly touched on there. However, there is a good alignment with the wider NHS long-term plan and potential for future rollout, which is what was really important about, as Leanne mentioned earlier, not just coming with a lot more solutions which actually don't have the resources or the long-term feasibility of working. So the first big idea, so that's joining up information and digital strategy, is the rapid advice component. So this works on the basis of same-day advice for GPs deciding which next step to take from a pool of on-call specialists. So this could be rolled out to wider teams and communication channels. The second idea is the virtual ward or hospital at home concept, and it's one that already exists elsewhere and is growing, having already received extra funding as part of the approach to tackle the COVID backlog. Integral to this is also a primary care support team, which is aligned with the proposal for rapid response, and again goes hand in hand with a long-term plan. Next slide, please. So in a little bit more detail, as a design team, we took away all the sketches and the fantastic work that we were able to gather through that ideation sprint, and we worked them up into this storyboard and prototyped it to envision how this future pathway might work. So I'm going to give you a high-level overview of this reimagined next day urgent care pathway and take you through each step. So step one would be a patient fainted and is feeling unwell. They decide to see their GP. Step two, GP checks patient in the surgery or during a home visit. Having provided care for this patient for a number of years, they recognise that something's off. They're concerned that the patient may need an urgent hospital referral to diagnose and treat the problem. Step three, if the GP wants advice on what steps to take, they can send a question to the rapid response. The GP can post a question to a pool of specialists using the rapid advice service, asking for expert opinions on urgency and the best referral process for this patient. They include a patient identifier, which allows the responder to see a shared view of the medical notes alongside the questions. They have that added context. Step four, the GP can send the patient home. At the end of the appointment, the GP explains that a care pathway is being planned and reassures that they will be in touch before the end of the day with further advice about what will happen next. Remote monitoring equipment could be provided if this is appropriate as well. Step five, the GP gives patient a booklet with emergency information and explaining what to expect next. It also contains information about what to do if their symptoms worsen and how to access emergency care if that's necessary. Step six, meanwhile, a specialist from the on-call rapid response team picks up the question, investigates and provides a response to the GP within the hour or that specialised time that has been agreed. The response provides advice regarding the next steps that should be taken according to the clinical risk and the urgency. The specialist may speak with the GP over the phone to ask extra questions or discuss the response if that's appropriate. Step seven, the GP receives the response from the rapid advice service and communicates care plan to patient. If advised, the GPs admit patient to the virtual ward or the hospital at home so that the next day urgent care can be arranged. Please note at this point that alternative advice can be given at this stage. It might be to do further investigations or a follow-up appointment or to send them to A&E. It should not always result in an urgent referral being made. Step 8, the consultant reviews the case on the evening with all of the information in the virtual ward. So this is happening in the hospital now. So meanwhile, the patient waits at home and is assigned a remote nurse to provide support. The patient and their carers are also provided with a view of the virtual ward to see updates and access the home care advice. Using the virtual ward, the hospital team can also communicate directly with the patient and their nurse. Step 9. The consultant decides patient needs to attend a scan the next day and offers them a slot to do this. These might include priority appointments for diagnostics, such as scans, x-rays, as well as consultations with specialists. A number of slots are reserved each day for patients being referred urgently from the virtual ward to make this possible. Step 10. The patient goes to hospital for a scan the next morning and followed by a same-day appointment to discuss the findings with a specialist. This one-stop care model minimises the number of trips to the hospital and ensures the patient is not left waiting for a long time before discussing their diagnosis and care plan with the medical team. I recognise that this is a really high-level snapshot of the ideas that we came about, and it is just the starting point to this solution. But Having said that, based on the initial estimations, as well as existing case studies which do exist, if we could save 10 beds each day across both York and Scarborough hospitals, this would equate to 3,650 beds being saved in the first year. Using the figures from an existing model in Bradford, estimating the cost saving based on that is a potential saving of £648,000 for the trust alone. Next slide, please. So to summarise, including everything that we've walked you through today, by the end of this discovery phase that we had created lo-fi prototypes for virtual ward and rapid service digital solutions, gathered early feedback on the concepts from stakeholders, including GPs and clinical staff in both hospitals, set out an action plan of next steps to further develop and test these ideas, which also included recommendations for a number of wider improvement initiatives that were identified through this work. And I will hand over to Marcia now to take you through that in a little more detail.
Thank you, Kira. So at the end of the project, we wrote up our findings and shared that with the trust, and we made a recommendation for 5 potential next steps. They were all complementary and could be taken individually or together. The first of those is the one in the top left of the slide here, which was to do a further phase of delivery to develop and test the next day urgent care design concepts of the rapid advice and the virtual ward in an alpha style project. The second was related to the other opportunities that arose during the project. So both Leanne and Kira touched on the prioritisation exercise that we did. Prior to that, we created what we call the opportunities board, which had something around 24 different opportunities for improvement. And we did a prioritisation exercise that resulted in those 2 concepts that Leanne and Kira talked about. But the others were all valid. And so what we suggested for the second potential next step was to launch another discovery looking at any of those. We have since talked to the trust about potentially looking at some cultural areas where just about how the ED is viewed and perceived by the other parts of the hospital and how communication flows between and to the ED. The third option was to develop a service design capability at the trust, and we have been in discussions with Dylan about that and his colleagues, because there is appetite for that for sure. The fourth option was to join a network of mutually interested stakeholders to examine what we've learned at York and Scarborough and to contribute to a wider kind of national conversation about urgent referrals. So essentially collaborating, partnering for future benefit. And the other thing that we realised, and Kira talked about how we had to kind of put some boundaries around the project to keep it within its time limit. When we were doing research and interviews, we were frequently advised by people to talk to somebody else or talk to another department, and all of those directions were really, really valuable and valid, but we couldn't pursue them all. So there is definitely, and we've produced a list for the trust of all the areas of further research that we think would be useful to conduct, and there were recommendations for specific changes that could also be investigated. And obviously the patient surveys that Leanne talked about, there's some analysis that could be done around that. So those were the sort of 5 different areas that we talked to the trust about pursuing at the end of this project. But we do know that it's really difficult in an environment where people have got their day jobs and people are saving lives and dealing with COVID to think about things in a slightly different way. So we know that there are some real challenges to how implementation takes place at the trust. So I'd just like to hand back to Dylan to talk a little bit about where those challenges are and his thoughts on that.
Yeah, no, thank you. Yeah, so I think first and foremost, it's important to note that applying this service design approach was something which was quite new to some of the staff in the trust, especially staff on the front line. So the thought that actually staff were being asked for their views in terms of how things could be different and the like was significant. So that was great, and it was also clear that you know, I guess to some degree, real change happens in real work. So the people who would have to make the changes are the people who are involved in doing it day to day. As Marcia pointed out there, you know, there are some fundamental challenges with the NHS and how it is configured and the different parts of it, and in essence, the point that was made that, you know, to some degree the project might have started at one point somewhere and then followed, sort of gone everywhere, but once you start following to other places, what was very evident, you might have, you know, gone into primary care, gone into other departments or whatever. So when it comes to actually making a change, you know, the challenges are it's wider than just what's in the control of the trust or a particular department in the trust. So often is the case, there is requirements for some wider system change. So so one of the things that we're really keen to do is to have some discussions. We've been having discussions with NHS providers, which is a body that provides training and learning and represents providers in the NHS, and having some discussions with NHS Digital about how we can use this to consider how we do service design. Doing service design with people is really key, I would suggest, in delivering success in the NHS. And I think from our perspective, we're really keen to talk about how we can overcome some of those challenges. The other thing to note is that we also see clearly there is an opportunity coming. So for people who aren't aware of it, in terms of addressing some of those issues, there is a lot of hope around the introduction of what they call the integrated care system organisations in future, and the fact that these type of projects might be commissioned across different organisations as opposed to just the one. And I think from our perspective, you know, we'll be really in the Humber Coast and Vale region, which is our integrated care system. That's something that we're going to be looking to do. So I guess the challenge for us then is how do we turn some of that learning into action, and that ultimately is the challenge. And in particular, how do we? The important thing is how do we free up staff who are embroiled in lots of day-to-day operational work? How can we free them up to help to implement some of the changes or actually deliver on an alpha? And that's our challenge right now. So yeah. So I think all in all, that's where we're at. I think one thing we have got for certain, if anyone wants to talk to any of these people, we've got a group of clinicians now who are enthusiastic in terms of really keen to for us to continue with this type of approach and way of working. I think what's important when you're developing the case for these, if anyone's on from NHS organisations, is build into the case the ability for some people to come out of day-to-day practice to work on these type of things, and that's something we're doing on all of our new projects going forward. So yeah, so all in all, a good success, although I'm conscious we've not implemented the results of this as yet.
Thank you, Dylan. We have a few questions in our chat, and I think we can just move straight into our question and discussion now. The first question has come from Jay-Z and asks, would this system work with System 1 or an equivalent, or would it require the acquisition of a new app? So System 1 is a clinical software, which I think some parts of the NHS use for a one patient, one record approach. Dylan, are you okay to answer that question? So would the system work with System 1 or an equivalent, or would it require the acquisition of a new app?
Yeah, I mean, I think it does, because of some of the limitations of from an integration point of view, we in York are lucky enough with a few others to be able to view patient data from primary care within our system, and vice versa. I think, but I think in this particular case, I think what we were looking at is a separate application. But what we would also be looking at is the ability to more seamlessly take any data that we've got, certainly from the hospital system to an in-house system, so it's easier to get data out of it, let's say. So the idea would be, we would have envisaged a separate application for this, which folk would use, but it would potentially pull data from our electronic patient record system in terms of, based on NHS number, basically, in terms of as a means of pulling some of that data through and data around the particular patients concerned.
Thanks, Dylan. There's another question from JC about, do you collaborate with teaching surgeries to test a service like this, or do you have to go through the politics of public health for each deanery? I wonder if Dylan, you probably got a view from the necessity of that from an NHS perspective, and Leanne and Kira, you might have a view from sort of service design and research perspective.
Yeah, I'm not exactly sure what that. I'm not sure I fully understand what that question means, but I think, do you collaborate with teaching surgery to test services like this? Yeah, I mean, I think I guess the point is that the people who've been involved in this project so far, in terms of testing this sort of service out, have been the people involved in delivering the service. Although, as Leanne raised earlier on, because of a difficulty in getting some of the key people, we did involve some junior doctors who were obviously involved in teaching, well, involved in learning, should I say. So so that was as far as it went. But it's a good point. We could potentially link into to the universities on some of this potentially. It could be an academic project or whatever to test out perhaps, but we didn't connect with any of those. No.
Yeah, I can just add, like, the way that we did like engage with GPs particularly, because I guess the hospitals were a bit closer because we were kind of working with staff, core project team members in the hospitals. GP surgeries, we kind of relied on the project leads, the clinical staff from each hospital who had connections into primary care. So we were given a list of particular GPs, and we kind of sent out an email to everybody asking them if they, or telling them about the project, asking them to be involved. And actually we found it's kind of related to the next question about, creating the environment for staff to take time out of busy and pressured roles. For sure, that was a big challenge. Really, really busy people doing really important work. We did have to be flexible around that, and it did limit how many people we could speak to. We tried to be very, very flexible in terms of like the times and being able to rearrange things at short notice. But generally, we did find that people they really valued being asked to input into this and the chance to make a change. And so, kind of really making that clear and making sure that their voices got translated back into the trust and into the project helped create that environment. Really, it felt like a worthwhile for those staff, and that they did prioritize making time for it, as well as us keeping things down to a minimum, being very, very focused in our interviews and things like, reducing down our 5-day design sprint into 3 workshops and things like that.
Yeah, I think just to add to that, I think what I would say, and I've worked with various companies in the past. One of the things that I felt that DXW and CCD brought to this is that it was very challenging to get people freed up. If someone's got an acute issue going on with a patient, or there's a workshop, then you know, obviously workshop's going to lose, let's say. So the fact that potentially different tools were brought to bear. There's a whole range of tools which can be used from a service design perspective, I guess, and all methods. And I'm conscious of the fact that DXW and CCD adapted to the circumstances we're in, a bit like that. You know, the QR code questionnaire, even basic things like leaving things in certain places and all that, where we couldn't necessarily do interviews. So I think it's really important, if people are engaging with the NHS with these type of problems, we've got to be innovative in terms of how we do that engagement. Yeah, so that I guess that's that was the answer there to the how do you take people out the busy practice. To be, you know, to some degree it's very difficult to do that. The other thing, of course, is for some people. So there's some people in every hospital, and I believe in every area, who are really enthusiastic about making change. So, you know, it's just identifying those people. So there's Dr. Phil Jones and Dr. Mike Harkness, for instance, in our trust, really enthusiastic about making some change because they can see the benefit, the long-term benefit for them. So I think that's a way of enrolling people into freeing up the time in many cases. So those two individuals basically worked on this outside of their shifts in their own time. You know, that maybe that shouldn't happen, but that's the reality of, you know, the NHS is, well, certainly our trust is under, you know, massive pressure to find time is very difficult. So I think there's got to be some enrolment conversations with people in terms of, you know, what's in it for them.
Thank you, Dylan. We have another question from Nick Garrett. The two big ideas were already being implemented in other parts of the NHS. What makes the service design process important to implementation rather than implementing ideas from the top down?
Yeah, I can take that. I'll have a go, first pass at that. So yeah, this idea of like the virtual ward wasn't new. It's something that's been tried in lots of different places and for different purposes, and the same with this idea of a sort of rapid advice thing. The importance of this approach and the value in it is that we're really understanding, for this particular context here in York and Scarborough, for specifically urgent referrals, what are the actual problems, what are the things we need to improve, and starting from a real understanding of that, then arriving at which solutions will address those particular problems, rather than just saying here's a tool, use it and let's see how it works for you. So really starting from an understanding of a particular problem space, how it's working now, the particular problems. And so an example would be, it was clear that this virtual ward, as Kira said, it's not going to work for every single patient journey. It's actually quite a specific subset that it works with patients who can wait safely at home, who have that support. It was very clear that this is not going to work if you just try to blanket impose it on all urgent referrals. So there's one kind of illustration of the value of doing this. You kind of understand, actually, if you just try to force, let's say, virtual ward onto all of urgent referrals, it's unlikely to work. And we had that understanding. Yeah, I think that's probably.
Yeah, I'd just like to add to that point as well, Leanne. I think the benefit, a huge unintentional benefit of this approach, is not only that you're actually looking at urgent referrals, but you're looking at the big picture. So you start understanding different areas of the service and the process where big changes to that could actually unintentionally affect urgent referrals or the focus point. I mean, one of the many things that came to light during this process was that discharge is actually having a massive impact on all of the stages beforehand. So even before someone's been given an urgent referral, the fact that those spaces and those areas are already under pressure and can't accept people, that is having an impact. And if we were to just take, right, well, it's urgent referrals and there's a solution for that, so we'll marry them together, you may actually have unintentional negative effects as well on the wider system.
I guess just a final reflection on that, it's not okay. I think like being aware of what's coming from the top down is really important as well. So like being able to see, oh yeah, this kind of what we're seeing here does align with this bigger long-term NHS strategy around, you know, rapid response or virtual wards, but just being able to meet in the middle, like understanding how the bottom up and the top down things actually how they meet and where they really complement each other.
Yeah, no, I'd agree with that. I think you know, I mean, I know Nick, so as Nick will know, I think the thing for me is that what this approach has demonstrated is at least it's demonstrated one view of the problem to the whole, as opposed to everyone having their different parts. So there's a greater appreciation and understanding of different people's parts of the problem, if that makes sense, and therefore an appreciation of that. So it helps us to move to hopefully more of a even if it's a whole system approach across York and Scarborough Trust, it helps us to move towards some of that, I think. So I think you know, that I think for me the service design approach is key, because I think all too often, compared to the top-down approach, well, potentially the people at the top, and I'll include myself in that, don't necessarily understand what the problem is, and can often do some knee-jerk reactions in terms of use this system, use that system, which may not provide, which may not address the problem, might even cause other problems. So I think I appreciate, and this is the difficulty with us really, it does take longer, but the value of understanding it, I think, it means that you come back, you come up with, well, solutions to the problem. So I hope that's helpful.
Thank you, Dylan. We've run over by 5 minutes, but we've still got quite a lot of people present. So we've got 2 more questions. I wonder if we could just try and answer those before we finish.
Yeah.
So one is from Andrew Halliday. He said, with the approach, would you anticipate repeating this for all of the 200 plus NHS trusts? And that would be fascinating, wouldn't it?
Well, is anyone from NHSD or NHS providers on the call? Because I think, you know, fundamentally NHS providers, well, NHSX, who are the, let's call it the policy making part of the NHS as it relates to digital, are advocating that we should be taking more of an agile and service-led design, you know, user-led design approach to change. So I think, you know, this is the fundamental, isn't it, really? So I would suggest taking examples of this, not saying this has resulted in the implementation of a sustainable solution yet, but I think at least the problem properly understood. So I think the big thing for me is the big call out and challenge. You know, we're keen to have discussions with NHS providers, with the NHS Digital, there's Tara over Marlin and people like that, to basically, you know, DXW and CCD aside, really, to say, actually, these are the type of approaches we need to be taking, and why, and here's an example. I would suggest that not every trust is different, not every trust is the same. So the 200 trusts might be in 200 different places with different priorities, different issues. So I think yeah, absolutely, we should be bringing the service design approach, but not necessarily, the solution from this might not be a one size fits all, if that makes sense. You need to do some level of service design to understand what's the differences and the variants. I think that'd be my point to Andrew.
Thank you, Dylan. And the final question that we have is from Naseem. He says, thank you for opening the door to this part of design. Were there any insights from the patients post-delivery that worked to support your research? Leanne, you mentioned that we tried to do patient surveys, and we didn't actually get the opportunity to fully analyze that data, but it's there, it's still probably valid. And
yeah, for sure. It's a great question. I haven't seen it, so I can't that we can answer that yet. But and I don't know, Dylan, you might know if anything has been done by the team, the medical teams in the trust.
No.
You have data, but that would be the jumping off. So we haven't been involved since delivery ended, but that would be a jumping off point for the next phase of the work, to pick that up and let's look at that. How does it support what we've recommended so far, and how can we do more to test and validate with patients? One of the things that we included on the survey was not an opportunity to opt in to take part in further research. So hopefully one of the key things from that is a list of people that we might contact to actually do more in-depth research.
Thank you, Leanne. Kira, I know you were quite heavily involved in the creation of the patient survey. Would you like to add anything to that?
I think Leanne's pretty much covered it, but it's just, just adding to what Leanne mentioned earlier, is about making sure that anything that you put out to patients is accessible as well. It's just another layer that we had to make sure that we integrated. So not only did we recognise the local demographics and actually translate some of the surveys into Polish, because that was an identified demographic, but also making sure that the language used is actually quite easy read, that all of the surveys can actually be used by screen readers or any other adaptive technology, making sure that you're actually widening that circle of patients who can actually input into this is really important, because often it's the people that have protected characteristics, for example, who are often missed in these opportunities because they're not accessible. So that's the only other thing that I wanted to mention as well.
Thank you, Kira. Yes, we're 10 minutes over now. I'd just like to say a big thank you to Dylan, Kira and Leanne for presenting that, and for the questions that came in and the comments as well. Thank you very much, and thanks to Leeds Digital Festival for having us as part of their lineup.
Thank you.
For your time.
Bye.
Thank you all. Bye for now.